on the agenda for this afternoon's meeting is the election of chairman. Could I have nominations, please?
Yes, Helen, I'm pleased to nominate Councillor Rebecca Knox.
Is Councillor Knox seconded?
Happy to second, Seth here.
Are there any other nominations? In that case, Councillor Knox, you are chairman.
Thank you very much, and thank you to Councillor Spencer Flower and to Seth White for your proposal and second, and thank you to the board for accepting those nominations. So I will go straight to the appointment of vice chairman, and I would like to propose Forbes Watson. Do I have a seconder?
Chairman, it's John Selgren. I'll second that nomination.
So are there any other nominations? Councillor Laura Miller has a request to speak. Laura?
Sorry, I was only going to offer to second that.
Okay, thank you. Forbes actually had sent his apologies today, but he's been a brilliant vice chairman, so I'm really pleased that we've proposed him in his absence, but I know he'll be delighted to accept the position. Before I go to apologies, I'm just going to say that in order to conduct this meeting on a virtual basis, welcome to all of those who are looking in as members of the public. We do have, we're working on Teams. We do have a chat room, but what I'd like to do is use that for right to speak. There is also the hand facility, so I'll keep an eye on both. I know that comments in the chat room are really helpful, and if you make one, then I might well ask that you say that to the board publicly, because normally most members put something in there if they want to have a conversation about something. So I'll keep an eye on that as well. But I think it's a really useful tool, but I'd like to be as transparent as possible with those who are looking in from the outside. I hope that's acceptable to everyone. If you wave, I might not catch you because there's only a limit of amount of people who can be seen on the screen. I'm all for keeping on the video if you would like to switch off your microphones, but I know that there are broadband issues and it can all come to a crash at times. But if you would like to keep on your video so that we can see you, that would be great. And particularly, of course, if you are speaking to an agenda item, making a presentation. So the next item I go to is apologies. Helen.
We have apologies from Patricia Miller and Forbes Watson, as you've said. Eugene Ufel is substituting for Patricia Miller.
Okay, lovely. We do have a core of the board. I think we will probably see some other people joining. Forbes is joining by the looks of things. Forbes, are you here now?
I am. I've just joined.
Oh,
sorry, it's a bit late. Yeah,
that's all right. We had received an apology, but you're here, which is fantastic.
All right. Well, I can go again.
No, don't go, because you've been nominated as vice chairman of the board.
That's fine. Thank you.
Okay, brilliant. Thank you. Right. Thank you, Helen. Those are the apologies. I'll now go to item number 4, which is the terms of reference. Does anyone have anything to say on the terms of reference? Sam, thank you. Sam Crowe, our Director of Public Health.
Sam.
Can you hear me now?
Yes.
Slight delay on getting the mute button off. Apologies. Thanks very much, Chair. I think the terms of reference are fine. I just wondered whether the board would support adding in a line to reflect the additional duties around outbreak engagement, which we agreed at the last Health and Wellbeing Board meeting. So it just needs something to capture and recognise that the local outbreak engagement board is a function of the Health and Wellbeing Board. I just thought that would be a useful addition if supported by board members.
Thank you, Sam. I think that's a very good suggestions, and it was agreed at the last board meeting. So if Helen, we can take a line of what we agreed from the minutes. It is now actually probably our most well, it is our most important role for the foreseeable future, and will be a standard item on the agenda. So thank you. I hope everyone is in agreement. I can't see anyone dissenting. So thank you. Let's move on next to the next item on the agenda, which is declarations of interest. Has anyone got anything to declare? No hands up and nothing, no right to speak. So I shall move on. Public participation. This is where members of the public who have previously written into the board would be able to put a question and receive an answer. So, Helen, have you received any questions or statements from the members of the public?
None at all, Chairman.
Okay, thank you, Helen. We'll now move on to item number 8, which is entitled COVID. There are 2 sections to this, and Sam, I think you're going to be first on the presentation list.
Thanks very much, Chair. So I will introduce the first item, which is about the COVID-19 communication strategy and our Trusted Voices project. I have to apologise a little bit about any background noise which members might pick up. I've got some builders on site today with rather large drills. So if at time you hear strange noises, I'm afraid that's my fault, but I'll try and be as clear as I can. So I was just going to start with a bit of an introduction to the paper, which I hope you've had a chance to read. The current national situation with COVID-19, and I think some of the announcements this week underline the importance of having really clear, good, strong communications and engagement in place. And as I've been reflecting on the work that we've done on COVID-19 through the pandemic, it's become increasingly important that we're very, very clear with the public about what we require them to do, both for themselves to stay safe, but also increasingly in order to protect others. But as we've seen in recent weeks, this isn't straightforward. And while most people, and particularly in Dorset, I think have complied really, really well with the public health guidance and the public health measures, at times it has been confusing to try to keep up with the changes in some of the guidance. And there's a definite sense, I think at least in national terms, that the government may need to start to rebuild some of that trust with the public. And I think we've seen that this week with simplification of some of the messages and simplification of some of the measures that are coming in, for example, the rule of 6. Locally, we're lucky that I don't think this has been so much of an issue, and that's partly through the excellent work that we've had through the Warning and Informing Group. So working with the Local Resilience Forum, we've had very clear and consistent messaging on COVID-19 that's gone out through all partners. We've managed to agree those messages in advance, even though in some instances partners have had slightly different approaches to how we've opened up services. We've managed to stay together on the really important core messages, and that's been really important in continuing to have the trust of the public. We've also had good feedback on some of the campaigns and messages that we've run, both through our public health channels and also through some of the campaigns with our partners. So the paper that we're introducing today is setting out our new communication strategy for outbreak management, which was agreed by the Health Protection Board. As you'll remember from the last Health and Wellbeing Board, the Health and Wellbeing Board plays a really important role, which we've just alluded to under item 4, in local outbreak engagement. And that puts the Local Outbreak Engagement Board at front and centre of efforts to communicate with our communities. We made a deliberate move to make sure that our local political leaders and board members were right at the forefront of that engagement, should the need to arise to change our messaging quickly in response to rising infection rates and outbreaks. And as the paper notes, the role of the Outbreak Engagement Board becomes increasingly important, particularly if we need to escalate situations. And the paper contains some clear examples of how we would be messaging at different levels under the Outbreak Management Plan. If we do need to signal a change, we would be looking to local leaders and myself to be front and centre of any messaging, and we would have to agree how we got that out quickly. So the communication strategy is a really important tool, I guess, in the range of levers that we have at our disposal to understand what it is that we would need to message, under what circumstance, and how we would do that. The other point I just wanted to make relates to one of the other appendices, which highlights the work of the Trusted Voices project, which I think will become increasingly important. So in some instances, if we started to face situations with particular outbreaks affecting particular segments of our community, general messaging may not be as effective, and that's where Trusted Voices comes in. So this is a database of more than 90 people who represent various communities across the county, not just geographical communities. In some instances, they are communities of interest. And this is very much a two-way communication project. So as the communications team starts to engage with that network and send them regular e-newsletters with messaging and key updates about COVID-19, we're asking those trusted voices to share them with their networks, but also in return asking for insights and feedback about how those messages are landing, and also what's of particular concern to particular communities. And we feel that sort of two-way communication will be really, really important as we get into the autumn and winter months. So just as a sort of final footnote, I hope the board will welcome the communication strategy and the Trusted Voices project. It did feel when we were developing this as if the local approach to measures would continue. And this was written very much from the perspective of local outbreak management plans being our defence against having to go back into perhaps tighter measures on a local basis. But as we've seen in the past week, the mood music has definitely shifted because of the national rise in cases. And we've seen the first tightening of national measures in response to the situation in the rest of the country. But nevertheless, we still feel that a local approach will be important, and certainly when we're continuing to build trust, I think that trust is best built on a local basis, and we're continuing to do that work. So I hope the board will welcome the report. I'm more than happy to pause and take any questions. Rebecca, are you on mute?
Hi, thanks, Sam. Sorry. I'm just going to ask members of the board if they've got any questions or comments on the paper and what Sam has just said. Yes, Spencer.
Very quickly, Chairman, I'd just like to fully support everything that Sam's just said. I think it's a very sensible and balanced approach. And I think, we've done extremely well in Dorset, and we want to continue with that. Yes, there is a change in the national scene, but it doesn't stop us doing what we believe is the best outcomes for Dorset. So he has my full support on that one. Thank you.
Thank you, Spencer. And the next person I've got is Councillor Laura Miller. Laura.
Thanks, Rebecca. Yeah, I just wanted to add my support really for this item. We've all encountered situations where we recognise that we might need to use this and refer back to it. And I'd just like to say thank you to Sam and all his team for the hard work, because I think it's a really comprehensive plan and strategy, and I would fully support it.
Thank you, Laura. And next I've got Seth. Why?
Thank you, Chair. Thank you, Sam. Just to reiterate the support from the others have shown, but also just to see, is there anything that we can do in terms of strengthening the communication to some of the vulnerable groups or the communities across the area? We have lots of networks and staff ourselves, and I would just want to be able to help you as much as we can. Thank you.
Sam.
Thank you, Seth, for the offer. And absolutely, that's why I raised the role and the importance of the Warning and Informing group, because we've had great support from our partners through the Local Resilience Forum. And at times we've used different talking heads, if you like, from different services to try to get some of those messages across. So Kirsty Hillier, who's the head of the Warning and Informing group, I'm sure would be very, very grateful for that offer of support. And if we need to stand up any different voices, if you like, to give the messages in a slightly different way, that'd be really, really welcome. So thanks for the support.
Thanks. And Seth, yes, I was wondering whether actually the Fire and Rescue Service were aware, or probably are now that I've heard from Sam about the group headed up by Kirsty about trusted voices, because the fire service, as you know, can get to places that others can't at times. So that to me seemed like a really good connection, and the same potentially with our friends from the voluntary sector. Alan has now joined us, so I'm sure everyone is well involved, but thank you for raising the trusted voices, Sam. That's been really helpful. I now have Forbes, please.
Okay, thank you again, really just to support the comments that have been made about supporting the plan and the clarity of it. I suppose the challenge we have at the moment now in Dorset is what is a proportionate response to keep things in steady state versus making sure we're not complacent. And certainly in the community outside of the hospitals, we're not seeing admissions, but we are certainly seeing an increase in activity of respiratory tract symptoms, which may or may not be COVID. That is complicated by the issues around testing. And it's just about what's the best collective approach we can have, and look to Sam for his guidance in that to, quite frankly, collectively protect Dorset as much as we can.
Thank you, Forbes. I think it's a really good and timely question. We had quite a lot of discussion in the SCG earlier today. The SCG is the Strategic Coordinating Group, so that's our Gold Command, which met earlier, about exactly that. And I think into this mix as well is not only the need to not overly create too much anxiety when we know that infection rates, thankfully at the moment, are quite low. But equally, that sort of tightening of the national message around increased enforcement around some of the national measures, we have to get a very appropriate balance, I guess, and avoid falling into situations where it may feel as if we're inadvertently blaming sections of the public for what may or may not be happening. So we are going to think very carefully about how we continue to do our communications across the system. As you said, there is rising anxiety with schools going back. We are very well aware that there's a lot of parental anxiety around what parents should do if children have symptoms that may or may not be COVID. The comms team, again, have been doing some work on a symptom checker. And we are working very, very closely with schools to make sure that we're keeping things in proportion and perspective. But equally, as you've pointed out, Forbes, the national evidence shows very clearly that in areas where infection rates have risen significantly, they are starting to see hospital admissions. So some of the early thinking around our comms messaging is how we play that message quite carefully to say, particularly around self-isolation, for example. If you look at the national evidence around self-isolation, we suspect that lots of people aren't complying with that 100% of the time. So we'll be starting to go a bit harder on that message, that even if you feel well, if you've been told to self-isolate, it doesn't necessarily mean that you won't develop COVID. And you may well feel as if you're okay to go out and about and interact in society, but please be aware that you could be inadvertently putting clinically vulnerable people, at risk. So lots of work to do. We need to keep that balance in mind. But again, I would value the support and the engagement of colleagues around the board just to make sure that we get those messages right.
Thanks, and Forbes.
Thank you.
James?
Yeah, Rebecca, Sam's probably covered most of what I was going to say. We did discuss this at the SCG this morning. The messages were clear from government yesterday that both the penalties are going to strengthen, and there's an expectation on all of us to change the posture around enforcement. And we, of course, we would support that, but we have to do that in proportion to the threat locally, and to do it in a way that doesn't lose the support of the public that have been very, very compliant throughout this outbreak. So we're working at those plans. There's an extraordinary TCG, a tactical coordinating group that's meeting on Friday to discuss how we share resources to make sure that the public get the level of enforcement they would expect, which is appropriate to the threat. I hope that's of some help.
Yeah, thank you very much, James, for that assurance. I haven't got any more from the board at the moment, but just a quick question, Sam, and this might not be for you, it might come later. The local action cards. I know that there have been templates for hundreds of local action cards which have come down nationally, and in fact in Dorset what we've been doing is looking at the ones which we think are most pertinent to the types of business and communities we have. This has been a huge amount of work, I know. Do we now have to go and rewrite them all overnight because of the new announcements from yesterday?
No, I'm hoping not. I mean, most of the action cards are fairly generic standard operating procedures. And in fact, what the local teams and support through the Health Protection Board have been doing is to contextualise them. So on their own, they're of little use because they are fairly generic. What the teams have been doing is working through all of those high risk settings, looking at the standard operating procedures and then producing almost like a wraparound framework, which goes alongside the action card, which has the key settings, the key contacts, the key actions localized so that we've really got the right people connected and engaged with what needs to happen under what circumstance and what situation. So they've been like a series of mini tabletop exercises around what needs to happen with good engagement. And the board has signed off the first 6 of those. Those are the 6 that we feel present the highest risks locally. You're absolutely right. There was a big deluge of cards which we're starting to work through, but we've picked out probably those that are most important. There may be others on the call that want to come in with an update, but that's where we are on those for now.
And help in distributing the message again. Are those members of the board aware of how within their own communities there might be the ability to use some of the action cards? Maybe that goes through Kirsty's group.
So I think the action cards very much for officers engaged in the day-to-day response. So if there are particular incidents and there's an incident management team, it covers the essential actions. What the communications support would be doing is to look to see if there are any consistent themes or patterns coming out from some of those incidents, which again, the Health Protection Board discusses alongside our local epidemiology, and we start to form and shape some of those messages through the Health Protection Board. And in the last week or so, we've moved to a more rigorous closing off of the meeting where we would summarise any key themes, key actions and key messages for the wider system, and that will then be circulated among partners.
Okay, thank you very much for that. Are there any more suggestions, comments, questions on Sam's item? I can't see any, so thank you, Sam. I think you're passing over to, is it Emily first or Paul first?
Thank you, Chair. I think Emily Merrill is
Emily
going to present.
Emily's on my list. Emily, are you there? Paul's there. Paul, you have your hand up. Paul.
Yes, good afternoon, Councillor Knox. I've been mailing Emily. She's not with us yet at the moment.
Okay.
So I guess we could either wait a couple of minutes or
well, you're there.
change the items around. Yes.
So if you're there, shall we take your item? Would that be all right, board members, if we go with Paul's item, which he was going to be on at item number 9, I believe, and Emily was doing a follow-up to Sam's number 8. Is that all right, Paul, or have we caught you on the hop?
No, that's absolutely fine. That's absolutely fine. Are you okay if I share some slides with the meeting?
Absolutely, that would be great, and I'd like to thank Paul for all his help in ensuring that we've got a really constructive, excellent, up-to-date agenda, and with the latest information. Hence, probably the lack of papers, but incident issues are really important on this one. So, thanks, Paul. And when you're ready.
Okay, thank you very much, Chair. So this should be coming through. Yep. Could Councillor Knox, could you confirm you can see the slides okay?
I can see Dorset Health and Wellbeing Board, 24th of September.
Great, thank you. Well, good afternoon, everyone. I'm Paul Iggulden, and I'll be leading on this item to give you an update on the Joint Strategic Needs Assessment. Be a bit of a double act with myself and my colleague Chris Skelly, who will pick up the baton shortly. I'll give a brief introduction. So a little bit of context. Just to say, I'm pretty new to the team here in Public Health Dorset. I joined in February to give a little extra capacity across a number of areas, and in particular around the JSNA agenda. And February, early March, we made a good start on developing a programme of work to develop JSNA. But then, of course, things have changed and COVID-19 came along. So our plans haven't been developed. Well, the plans there, we haven't delivered on them as fully as we would have liked. So I'll be sharing with you today an update really on the work in progress that's going on to develop the JSNA across Dorset. So we'll be covering a little bit about how the website pages are being updated. And then I'll hand over to Chris to give you an update on where we are around the insights work. Just say a little bit about the insights work. I have to say, I find it a very exciting development. I've worked for a number of years as a freelancer, sometimes in salaried roles, up and down the country in different local authorities and PCTs in the past, and have been involved in a wide range of needs assessments. And often these will have a section which refers to what more we need to know or what information gaps that we might have. And quite often that section will talk about the need to better understand local views, local professional opinion, a sense that we need to do more qualitative work. And the Dorset Insights work very much begins to address those gaps. And so I'll hand over to Chris shortly, but just a little primer there. I think this is a very exciting development for us locally. So, apologies, I've just realised that I'm showing the wrong set of slides. I shall stop showing these for a minute and find the correct slides, because it won't help Chris at all if I show the wrong set of slides. I do apologise. Bear with me just 1 minute. Okay, can I just check you can see a new title page?
Yes, thank you, Paul.
Thank you. So we'll be familiar with the JSNA. It's there to help us understand needs, to support our Dorset work, and to support us in identifying key issues to follow up through joint health and wellbeing strategy. And as with areas up and down the country, routine data very much underpins our JSNA. But as I mentioned earlier, I think we're looking to go one step further locally with the insights work, which helps us to then combine the numbers with the narrative. So our plan for 2021, and as I mentioned before, this has been a bit derailed by COVID, but we'll be working as much as we can on this agenda through the remainder of the year. Big focus on updating the JSNA website pages. That will allow see us bringing in more of a sort of library of resources for people. So we'll be updating locality profiles, which I'll say a bit more about later. Looking to summarise the insights from the people and system insights work, alongside publishing needs assessment reports and pulling together a data repository. Chris will tell us a little bit more about the insights work shortly. We'll also be looking to try and bring back to you as a Health and Wellbeing Board, each of your meetings with your permission, the strategic issues which are surfacing from those insights pieces of work, and in particular the People's Insights work. So new look web pages. The bullet points on the left give us a structure for the website that we're working towards. So brief introduction, a welcome and introduction, the plan that I referred to in the previous slide for the year ahead. Then this notion of a data repository, a collection of needs assessments and related documents, and then some detailed findings from the insights work. So I'll just tell you a little bit more about the data repository. This will allow us to make available to people a wide range of data sources. We'll be looking to make available things we worked on locally and linking through to key work from other partners locally and further afield. And we'll look to structure this as per the bullets here, a sort of population focus, then a life course, some themes around healthy place before looking at morbidity and mortality. And this structure that we've mentioned here is one which is echoed in some sort of supporting pages around locality profiles. So we've done some work very much earlier this year looking at updating locality narratives for each of the 13 localities and making available a dashboard to support locality level work, which pulls together a range of 70 indicators from a Public Health England product called Local Health, and again structured using the bullet points mentioned on this slide here. Insights. The insights-based work focuses in two sort of key areas: system insights and people insights. The system insights will help us in supporting and understanding needs and service improvements. Very much looking at how subsystems within the overall system what challenges they face and how these might be addressed. And the people's insights, the initial phase of this work, we're looking at working with health and wellbeing workforce partners, again, to better understand strategic issues and what might be done about those. And then looking to the future, we'll be looking at rolling that out and looking at working with other key stakeholders, such as the public and local communities. So that's a brief introduction from me, and I'll hand over to Chris now.
Thank you, Paul. Hello, colleagues. I'm going to keep my camera off because I'm suffering bandwidth limitations where I am. I'm going to present some system insight work today and a little bit of our people insights work. We do have a third insight stream known as strategic insights, which is about futuring or foresighting, but we'll leave that for another day. We have been looking for some time as we transformed the way we've undertaken public health intelligence to find ways of engaging everybody in our system more effectively. And the approach that we're taking is co-working, unapologetically trying to develop collective insights and collective intelligence, getting everybody work together. Now, there's a lot of reasons why we might want to do that. But one of the resounding feedback we're getting from the people that we're working with thus far, and I'll run through the panels that we've set up, is that that this is an excellent way to move forward. They feel really engaged, the topic groups, and I think we're going to add some really important understanding of why the system works the way it does. And this is exactly what we need when we're trying to consume the vast amounts of data that we currently have. And of course, you have to start a talk with a quote, and I think the Albert Einstein quote about insanity, it's got a asterisk there because I think it's apocryphal. I don't think he ever said that, at least not in the context the way I'm using it. But we do need to try different things, I think. And Paul, can we move on to the second slide? So what I'm going to bring to you today in terms of system insights, I'm going to focus on one panel group that we've been working with. And they were largely based in and around the Dorset County Hospital. They asked us to come and help them develop some system insights. And we said, ooh, could we make this a JSNA panel? And they said, yes, please. So we've developed a bit of a story. 3 really interesting, I think, and important key insights were developed during the workshops we ran with this group. And the first one is that when we increase urgent and emergency care funding, it doesn't reduce the demand. It doesn't even slow the demand for those UEC services. And for those who might not be aware, the urgent and emergency care services that our NHS offer is pretty much an open door. Sometimes they're a last resort for people, but they're always there, and it's very hard to control who's coming in that door directly. And if we look at the little loop we've got at the bottom of this diagram, the UEC challenge, we see that we've diagrammed this as urgent and emergency care needs. As they go up, they're driving up waiting times. That's not a surprise. That's very visible. And that sometimes drives down the quality of care. Often the government response to this is extra funding to solve these visible issues. Okay, and so that doesn't impact that demand driver that we've got in that loop. The second insight we had was that effective disease management, although necessary, may be insufficient in terms of the overall response to stabilizing both the budget situation, the waiting time situation for urgent and emergency care. And if we look at the disease management loop above that, we can see that we've got urgent emergency care needs. They impact on health and well-being, which then impacts on the effectiveness of our disease management. And our response has been, in the case of developing an integrated care system, to try and develop a more cohesive and collective effort in managing disease so that people don't reach those crises points. The third key insight that the workshops produced was that if we want to prevent disease, we must address the lifestyle and living conditions of the population. We need to look into the community. If we follow the loop on the left-hand side, health and well-being is being impacted by the accumulation of risk factors that all of us will encounter over a long lifetime. This in turn is impacted by how we live our lives, and most importantly, the settings in which we live our lives, which impact on behaviors. And even though you and I, and many of us that are listening in today might be doing just fine, as Duncan Selby would say, we have work, we have employment, we have a healthy home, and we probably have a good friends network. That isn't true for everybody in society, and we know that socioeconomic inequalities have been impacting increasingly large segments of our society over recent decades. All these are important drivers. Now, if we peel back this layer and we look a little deeper, Paul, we'll just go back one, or sorry, go forward one. If we were to look a little bit deeper at this and we took the iceberg model, what you can see at the top left, UEC challenge, is very visible, isn't it? Because you walk into a hospital waiting room and you're always going to be seeing lots of people and sitting and waiting for a period of time. That's easy, it's visible. Disease management, although it increases the leverage to make change and to start making transformative change, it's harder to see, isn't it? Because that's happening in primary and secondary care encounters with patients, millions of them each year. Even more leverage, and I would say this because I'm in public health, is disease prevention. Start with the true drivers of the disease in the first place before it becomes a problem. And this is incredibly hard to see, how people are living their lives, what's going on in their homes and their workplaces and so forth. Very hard to see, but increasing leverage can be gained for system change by focusing down into those things. Paul? So the group peeled back the layers and we looked at this in more detail, and a more detailed insights analysis broken down into 3 short points are, why do people use urgent and emergency care services? And we had a very long and very interesting and unresolved discussion about what's a necessary versus an unnecessary visit to an urgent and emergency care. And it's worth knowing that there seems to be a fair bit of disagreement about that. The second thing that we had a lot of discussion about was the short-term improvements that we could make to the system. And if you look at the top 2 loops of this diagram, on the top right-hand corner loop, unnecessary visit reduction in the short term was about the quality of the relationships within the urgent and emergency care system partners. And we talked about the ambulance service, we talked about how care homes operate, we talked about a number of partners, primary care and so forth. And then if relationships were improved there was a general consensus that they felt they could reduce unnecessary visits to ER, to the emergency department, and this in fact would benefit everybody. And then there was an equally long and perhaps even longer discussion around the long-term changes that we might want to make and about improving the social conditions of living, and indeed on funding population health interventions or population health improvement activities, which overall will impact on things that you couldn't get to by short-term changes to the system. And I will just say on the bottom right-hand corner, there's this classic fix that fails in systems thinking, which is what I mentioned in the first slide, which was all about you have a system which has increased waiting lists. This concerns the public, it concerns all of us, and the response is to put more money on treating the symptoms. That is increasing the capacity of the urgent and emergency care system to treat people, but it will still get overwhelmed later in the future. All right, Paul, if we could go to the next slide, please. Peeling it back, and we had a much more detailed discussion. It's complex, right? And that's not an excuse. That's a realization that there isn't any one big thing in the UEC that can be fixed. There isn't a silver bullet. There's no magic lever that anybody can pull to make this all right. There's lots of things that are interacting here. And the general consensus is, amongst everybody who participated in these workshops, is that there's lots of things we can do, and it's more about nudging various parts of the system, hopefully in the same direction, towards a goal. And we'll go to the next slide, please, Paul. And if we were to take a much more traditional look at urgent and emergency care, you're looking at a graph of UEC admissions 2004-2019 for all of England. So this is care data for England. And you can see that in 2004, there were somewhere around 4.4 million visits. And by 2018, 2019, we're looking at about 6.2 million visits. That's a very steady increase. There's no indication that that demand is going to slow anytime soon. What are the drivers of that demand? Why is the system working the way it is? How much time? The second point here is how much time will be improved by disease management. Sorry, that completely made no sense whatsoever. How much time can we buy by having improved disease management in the system? Because if you improve, let's say we can reduce admissions by 10% by all getting together and making sure that somebody's diabetes is under control and they're taking all their medications and they're doing the right things, that's still a stagnant or a once-off change. There's no disease management which is going to give us indefinite improvements in effectiveness. So we have to realize that part of the system moves in stages. And finally, how much disease prevention would we need to stabilize the UEC system? So that is, how many cases of diabetes would we need to prevent from ever occurring in order that we could bring this curve down so that urgent and emergency care isn't overwhelmed 5 years in advance, and if we fund more capacity, that it will last beyond, you know, the next decade. How much? These are the things that the systems work, that the insights that we're developing there is focusing the data questions on. So the next steps, Paul, are to look at this and take the same similar approach in a number of different areas. So we're working on about 12 areas at the moment. Food insecurity is one of the areas that we started in. Urgent and emergency care is the one that I've been talking about today. But we've been working with groups all across the system, and they're in various stages. So by the time that we get through the end of this year, we should have a very comprehensive website with needs assessments and insights in all these different areas. We've sort of paused panel recruitment at this point in time. Everybody's got other things to worry about, but we've got a lot of information that these folks have provided in workshops that we're working through at the moment. Paul? I'll just leave you with another quote on this one. We really do need to switch up our thinking, and this is why we've been working so hard to try and do some co-working and bring people into the process. And I think the next slide is the people insights. Do we want to pause there for questions or at the end? What would be your preference, Councillor Knox?
I'm happy to continue. I'm finding it quite fascinating, actually. I'm thinking that this is really interesting, and how, as a board, we can use this in order to form a system-wide approach to the early intervention prevention agenda. But is anyone putting their hand up? Not seeing any hands at the moment, so but please use the chat bar if you want to ask questions. So thanks, Chris. Carry on.
Okay, I've only got about 4 more slides, I think. So accompanying the systems insights, which is very much a group effort where we work with people, we've got a parallel process of people insights, where we're interviewing members of our workforce in every area. I think we've done about 60 interviews thus far. I say we, but it's my hardworking team that's done all the work on this. And what we're trying to do by interviewing people in depth is to explore something called a hidden mental model. And I think if we go to the next slide, Paul, the hidden mental models are the things that we view the world through. It's sort of a lens that we kind of get in our minds how we think things work. And as we explore them, we're finding 4 themes. 4 themes are coming through here. So the first is this realization that we have complex need in the people that we're dealing with. Multiple health and well-being challenges are being faced by people that we're seeing, in particular, not exclusively, but in particular, low-level mental health issues, regardless of which area we might be looking at. And we've got a quote here, which I'm going to spread over 2 pages because it's such a good one. And this particular person who was interviewed is a general practitioner. And in regard to the complexity issue, I'm going to read the quote. I think we need to try to emphasize prevention, but it needs to be embedded in the whole culture. You can change something a little bit, but if you're going to transform it, you need to think completely differently about it. You need to think about where they're living and all that other stuff, parenting classes, ... And people from members of our workforce all over the place are facing these issues. That's this complexity that we've got things. And it leads into something that we're all interested in, and that is effective partnership working. It's widely recognized now that working in our little silos is increasingly difficult to solve problems. And this underpins a lot of the systems thinking work that we're trying to do. Overwhelmingly, the people that have been interviewed, 60 of them in all sorts of different walks of life, are seeing a need for both strategic partnerships. They see what you senior executives are doing at the big picture, and they also see the value for strong on-the-ground working relationships between different groups. I'll continue with this particular quote because it also speaks to this really well. But you need to get everybody engaged in this process and somehow work out what you need to do and how to get that message out there. And working at scale is definitely the right way forward, working together. So somebody who's seeing patients, and I think everybody here has probably been to a GP. I experienced this when in those system insights workshops as well, where people are who might be an emergency physician start talking to me about drug and alcohol programs and talking to me about people who just want to come and talk and are socially isolated and all these other things that are in the community. So it's up to us to really try to understand the why our system is working the way it is and why people see things the way that they do. And these are very positive things. We go to the third theme, Paul. Inflexible processes. So this isn't something that's necessarily quite so positive all the time. A lot of our staff are seeing processes that are inflexible, or the complexity is hindering their ability to deliver or their ability to collaborate and engage with people. And we've got a quote here from a midwife that we've interviewed, I think about a year ago. There's a fine line of matching one criteria to the other. She's talking about multiple programs. So there's a little bit of gray area, a little bit of wiggle room, but there's too many issues for one, but there isn't enough for the other one. So they fit into one program, don't quite make it into the other one. So they're having to make referrals that work and so that they get some support, but not necessarily the support that that particular professional thinks they need. So there's compromises going on. And it's not, I don't think they're always about inflexible processes or the complexity of those processes necessarily, but this particular issue has come up several times, enough times that it's become a theme that's emerged from these interviews. And theme number 4, Paul, communications. And this is really all about encouraging people to engage, not just engage with our services and with our programs or when we try to help, but in any form of collaboration that might bring in community assets, because we know that there's lots of community assets, and we talk about these resources, these people within our community who can help out and can help change change the community in its entirety. We've got a voluntary sector representative quote, which is quite good. We signpost. I don't think that perhaps they engage, they're talking about the client, as perhaps they would if we could actually sit down with them one-to-one and talk through the issues. So their limitation was, in terms of the communications, was that they provide signposting. Here, you can go here for that, you can go here for that. But because of time constraints and their particular resource constraints, they're not able to sit down there and actually have a good conversation about that. So it's a rather quick process. So they felt that the communications, and again, this has emerged as a theme because we're hearing it time and time again, the communications that would encourage engagement in solving problems, solving their own problems and their own community's problems, are fundamental, but we're just not quite there yet. And Paul, I think that was the last one, unless there was one final slide. No, that was it. Okay. Happy to entertain questions.
Thank you, Chris, and thank you, Paul. There's a huge amount there, isn't there? But great work. Comments, questions, suggestions, feedback, members? I'm not seeing any hands or anything at the moment.
No worries.
Sam is here for a little while longer. Sam, please.
I'm hoping to get a message from her.
Thank you, Chair. I'm going to have to join a regional call shortly, but I just wanted to, I guess, highlight just the powerful evidence coming forward from that insights work. It's incredibly rich. I guess the real challenge is now how we would turn that into actionable insights and take that forward in terms of our work in the integrated care system. And I know that the team will be starting to think about that, but I was just really struck by some of the power of those stories. And particularly, professionals are often aware of this and just as frustrated by some of the consequences of the system as sometimes the stories that we hear from individuals. But apologies, I'm going to have to leave you all now, but thanks for a really engaging presentation.
Okay, thanks, Sam. Alan, welcome.
Can I pick up on the last item there, Chair, if you're hearing me? Which was the communications with the voluntary sector. What I'd like to just add there, Chair, if I can, is the great work that's gone on through lockdown by the Dorset Community Response Team, which is under Laura Cornett. But there's some fantastic work that's gone on across the county, and the relationship with the voluntary sector and the council now is greater than it's certainly been in my experience. And we are, as a sector now, in contact with all of the, I think it's about 166 voluntary groups across the county, some established organisations, some that have sprung up, all such that I think we should do a presentation to the November board here on the work that the council has promoted under the community response team, because it's unique to Dorset from what I can find out, and the working relationship is excellent. So I think the final point, the communication with the voluntary sector is in place and ready to go and work with public health. I mean, it's there and ready through that particular group.
Yeah, we were quite surprised. I mean, we certainly include the voluntary sector as part of our workforce, doctors, nurses, people in council, social workers, etc. We have members of the voluntary sector involved in at least half our panels. So they're pretty much ingrained into everything we do. Okay,
but as a county-wide organisation, you've got access via the community, the Dorset Community Response Team. So yeah. I'm just thinking about no need to duplicate too much effort. There's an awful lot of information out there in the sector as a whole, and Dorset Council have supported this group to a fantastic extent.
Okay. Thanks, Alan. There are some comments coming up. And I don't know if Vivian wants to say what she was reflecting on. I would, Vivian, are you there to say that? Because I absolutely agree with the statement, which is about how we move this into action. Vivian, do you want to say anything?
Just to say that, really, I mean, excellent, and it was so good to see that wealth of information coming forward, and the timeliness of it, despite the delay with COVID, is absolutely now, isn't it? Given the pressures that we've just been hearing about, that Sam's talked about earlier, and with COVID and with the resource shortage that we're all seeing, and the consequences of some of the behaviours and the information that we know already. I'm just absolutely delighted to see this, Chris, and really welcome it in how we work together as a system to really embed, a proper approach to early intervention and prevention. And also, how do we do that sort of upstreaming approach to sort of people supporting their health and well-being, and as we develop through the system, your example of how do people get to the emergency front door, and what's that journey? I think that is something as a ICS we're all looking at, aren't we? About how do we get that real home first approach and that prevention and community focus. So really welcome that, and look forward to how we're going to work on this. And I know my directorate are very excited about moving this into action. So thank you.
Thanks, Vivian.
Thank you, Chair.
John Selgren.
Thank you, Chair. John Soberlin, Executive Director of Place, Dorset Council. Just again, can I just thank our presenters this afternoon? It's a really, really fascinating, stimulating presentation, and all the hard work that's gone into bringing that into such clarity this afternoon. So for me, I think I'm going to pick up a flavour of a couple of colleagues' comments that have gone before. So I think, again, it brought home very sharply this afternoon the extent to which, sadly, our colleagues in health see presentations into their services which ultimately don't have a clinical solution to them. They have a social underlying challenge, so often relating back to housing or similar underlying conditions. And again, just to pick up Alan's comments, and again, in reflecting some of the services that I'm responsible for in relation to the council, the importance that we see in the role of universal services in actually making sure those people who don't have an underlying clinical problem are properly supported in the community through universal service provision and good information, advice and guidance, thereby hoping to stem some of that there's some of those presentations that are seen which don't have a clinical requirement. So I'm certainly looking forward to working with you and colleagues as we move forward, and perhaps bringing something to that discussion, that response, which is about making sure that we're maximising the capacity in the universal activity to keep the pressure on the primary and acute health services as low as possible.
Thank you, John.
Thank you, John. And that sort of to try and link up with what you and Vivian were saying. Chris, there's obviously some more work for you and the teams to do, but there's already, you can almost see from the extent of the work that you've done, there are places within both John's and Vivian's and others areas where already they could take some of that information and try and break down some of the process that maybe system process we've got in there which isn't necessary. We need to build in a culture change. So where is the next place this goes? Because I'm acutely aware that work doesn't just happen at this board. Yeah. So is there something that you've got an ask from the members of this board, you and Paul, about how that interaction with John's and Vivian's and others teams can put this into practical solutions?
Yeah, absolutely. So I'd say number one, we're all working in various systems and we see systems everywhere we look. If you've got an area where you'd like to do some work, shout out. We're not being directive on this. We're saying that our colleagues know what they're doing and we're here to help facilitate these sessions. And if it looks like it's of wide enough interest to people, we'll build it in as a JSNA panel. We didn't, maybe we'll save it for the next meeting. How do we stitch all this together so that you've got a resource that you can walk away from? Moving away from the traditional statistical compendium that many JSNAs are, we're still planning to have a report that says why we think things are happening the way they are. Why is the system producing poor outcomes is what we're mostly interested in. And here's the data attached to that. With up-to-date data sets and so forth available to you as a reference. Or you can always just pick up the phone and give me a call and we'll put you in touch with the person who's got what you need that helps you with your change. I think the fundamental underlying component of systems thinking is that the dynamics of the system are inherent in the system. It's not what we do to that system. So it's within our remit, it's within our kin, if it were, to change the dynamics of systems in some ways, mostly through nudging. And we're hoping that this information will help people modify the systems. And we see this all the time in the health sector when they implement new models of care.
Yeah, no, I see that. It's getting it out on the ground, isn't it? And that's through the help of those on the board and their staff. John, is that it? No, it's down. That's okay. So the next action, it seems that we come back again at our next board meeting to see where we are, maybe to see how any interaction between your team and those members of the board have progressed in any way, even if it's just contact made, to produce a further understanding of how we can turn this into positive outcomes. Paul, is there anything else you want to add from your end?
No, thank you, Councillor Knox. No, I think that's fine. Thank you.
Whilst I have you're still at the meeting, there was potentially going to be a paper on the discharge to assess. Before you disappear, if you are going to, can we put that onto the next meetings? I don't think that.
Yeah.
Yes. Thank you. Just for clarity, because I think that links into this very much, though, doesn't it? If we're looking at access to emergency care, but the discharge element is equally as important. Right, members of the board, is there anything else anyone would like to raise, or should we move on to what was the item before? Because I see that Emily's joined us, and she will be going on back onto the agenda item number 8. But thank you both. I can see that actually making a huge impact on lots of policy thoughts within all of our organisations and change. Right. So Emily, let's move back to you. Are you okay to do your part of agenda item number 8 now?
Yes, I am. Hello.
Brilliant. Okay. Thank you, Emily.
I've also got Dr. Simon Yule here with me today. We're going to do a little bit of a sort of joint effort on the presentation. So I just wanted to welcome her into the meeting as well.
Yeah, absolutely. Thank you, Simon.
So good afternoon, everybody. If someone could just confirm they can see a slide on their screen, that would be helpful for me, just to check if it's visible.
Yes.
Perfect. So I will apologise in advance. I know there's a number of you on the call today who have heard me present this. I think I've probably almost lost track of the different teams and directorates that I have shared this with over the course of the last couple of months, which is fantastic. But hopefully it'll generate some good thinking from the meeting today. So good afternoon, everybody. I am Emily Merrill. I work at CCG as the Population Health Programme Manager. And as I mentioned earlier, my partner in crime, so to speak, Dr. Simon Yule, who is the clinical director for the Vale PCN and GP, as well as a clinical lead for the population health management work within Dorset. And we've been asked to come here today just to share with you some of the most recent population health management insights that have been developed in support of a PHM-led approach to reset and recovery within the COVID landscape. I'm going to be providing you with a brief overview of the PHM journey in Dorset to date, for those of you who may be less familiar with the PHM-led work within Dorset. And then give you a bit of a rapid sort of walkthrough of the latest PHM insights before I hand over to Simon, who's going to share with you a real example of how she started to use this intelligence within her own network to strengthen the Vale's offer of support and care to members of their community to best meet their needs in the round. So I'm not going to go into too much detail in terms of what population health management is, because I'm conscious of the fact that there'll be quite a number of you on the line who will already have some understanding of that. But I think this is actually quite a nice, Chris provided quite a nice segue almost to this presentation today, because obviously population health management is about using data-driven insights and evidence of best practice to inform more targeted interventions to improve health and well-being of particular populations and cohorts. And the data that I'm sharing with you today, our PHM analytics, allow us to do exactly that, to move from system level right down to individual level, to really be able to identify cohorts with particular needs that we can best target resources and best support. So in Dorset, we have an ongoing drive to embed PHM as an approach to planning, designing and delivering services, really because we widely believe this to be the cornerstone of us achieving our ambition of becoming a thriving integrated care system, and for our PCNs to mature and develop in support of that aim. And as many of you will be aware, the focus of that population health system is about moving from individual care to groups within the population and is outcomes focused. And that reaches beyond networks and requires that multiple MDT style working across the integrated care system that Chris mentioned earlier, driven through really close partnership working between providers. And this is really important for PHM if we're to address those more holistic needs of the population in a round. So some of you may already be familiar with the Dorset Intelligence and Insight Service. You may have heard it referred to as the DICE, and will already have seen the Dorset system level dashboards that were rapidly developed early within the COVID response by our business intelligence team. And I'm just showing a few examples of those on the screen now. These were provided particular data in support of early response and reporting on behalf of the integrated care system, both regionally and nationally. For example, number of confirmed and suspected cases of COVID by primary care network and practice, demand and capacity reports, and many more. And these will continue to support planning and response and will evolve and continue to develop over time to best meet the needs of our providers. Separately to that, but complementary, is a suite of population health management focused insights, which include intelligence around specific disease areas such as diabetes, COPD, hypertension, frailty, and also high intensity users. And we have in Dorset, I'm proud to say, some of the most advanced PHM analytics in the UK. And this is a real asset for us as an integrated care system to use in order to enable intelligence-led planning, design and delivery of services, not just within primary care, but across our whole integrated care system. And during the course of the last few months, our PHM resources have been actually repositioned to provide NHS, local authorities, acute trust providers, that intelligence to deliver best health and social care for the entire Dorset population. And today I'm going to be specifically focusing on the recent addition to this suite of PHM insights, which focuses on understanding the needs of our local populations within the COVID landscape, enabling us to segment our local populations using known risk factors and by groups based on shared or common needs. We believe that this is going to stand us in a really strong position for intelligence-led planning and delivery of services as part of that reset and recovery and beyond. For example, long-term condition management and enablement of a risk-segmented approach to those who are most at risk within the population, not just based on clinical risk, but also non-clinical need as well. So much of the activity over the last few weeks and months has been around those at highest clinical risk, our shielded patient groups. But now we can use these PHM insights to start to also look at our rising risk groups and get further upstream so that we can really start addressing some of those needs of those individuals who are more likely to be storing up problems for themselves and the system of the future. These are our high-risk, costly patients of tomorrow that are going to have the poorest outcomes that we can identify now and take targeted action to address. So you'll be able to see on the screen at the moment, this is the PHM COVID Insights report front page, contents page, which you can access through the PCN intelligence within the DICE. And this is an open source link at the moment, which I can share with the group after today. So any one of you can go in and have a play around. When you enter the report, you'll find that contents page, which will help you to navigate to a number of pages within those COVID insights. And what you're looking at here is the case finding insights. And you can use this report to understand your population segmented by a number of individual clinical and non-clinical risk factors. You can see that the population's been grouped, and those groups are across the top of the report there. And within the report, there's definitions to explain how we have grouped the population. You'll also note at the top, there's the ability to select by local authority, by primary care network, and by LA ward and practice name. and a date stamp to show you how up to date that data is. So to confirm, for those of you who are less familiar with using the PHM data, we receive a primary care data feed from System 1 into the DICE on a nightly basis. So the primary care data is never more than 24 hours old. We also receive secondary care data on a monthly basis, ED data on a weekly basis, and mental health care data from Dorset Healthcare on a daily basis. And also we're drawing on a number of other data sets which allow us to start looking at those wider determinants of health and bringing those into the view. So I just jump back there a moment just to highlight to you what I've selected within that case finding insights are housebound patients with 3 or more long-term conditions for the Vale PCN. And, you know, that may make us think about questions such as how we can ensure equity of access to services for those within that group. And they may be potential candidates for potentially a digital offer of support for long-term condition management, enabling greater access to educational tools, services such as pulmonary rehabilitation, enabling that greater control by the patient to manage their own care. And you'll also notice in the bottom middle section of the report, these cohorts, you can drill right down to individual level and request re-identification of those individuals so that you can start taking some targeted action with them. What I'm showing you here is a spatial focus, and we can use this report to understand populations at risk using a spatial view. And it's often useful in order for us to determine whether service delivery is meeting demand and need. And there's the ability to filter on specific clinical and socioeconomic and demographic factors. The socioeconomic vulnerability risks have been taken from a data set called Mosaic, which some of you may be familiar with. And this data set uses a number of data sources such as the census, benefits data, consumer surveys to produce general household characteristics. And we've identified certain households who could be at risk of being socioeconomically vulnerable, financially vulnerable, or at risk of social isolation. So just a caveat, the data is not definitive, but it's a very useful marker of risk to these elements. And we can make best use of that data to help us to surface where we may have individuals who have needs that extend beyond healthcare needs. So here we've selected community minorities, the ethnic minority group, and those are at increased risk of serious illness. And you can see here that's 40 patients within the Vale PCN, and the map shows where those individuals reside. The ethnicity data that we have here is actually, and we're very lucky again in Dorset, we've got 80% ethnicity data for our 800,000 population within Dorset, which again is quite unique. Other systems around the UK do not have that level of ethnicity data to work with. So here I've selected the ethnic minority group and those at risk of serious illness. Again, you know, this could be useful for us to understand perhaps some of the additional needs of this group, ensuring accessibility of services, in particular for these individuals who may not have English as their first language. Again, here I've just given another example of that spatial focus, selecting those with high BMI, hypertension who are male over 50. Again, just enables us to potentially think about those that are higher risk of COVID in the future potentially, and maybe also higher risk for development of long-term conditions such as diabetes in the future. So again, food for thought in terms of how we are designing and delivering services, and in particular those that can ensure preventative measures are in place for individuals such as educational sessions, etc. So here's our COVID-19 focus. You can see here I've just selected COVID positive patients who are at increased risk of illness. So here we're able to use this report for identifying populations who have had COVID, and those that may have added social vulnerabilities which may make their personal journey to recovery perhaps more challenging. Again, considering how we might draw on wider resources in an integrated approach to meet rehabilitation needs. We have a mental health care focus. Here I have just selected as an example again, those people who are registered carers with an active mental health referral. You'll also notice a number of these people are also shielded patients and or have financial challenges potentially. And they will certainly require that integrated response to ensure that they stay healthy and well. So this is the last page within the report that I wanted to speak to, and I think it's probably, well, not probably, definitely my favourite one, because it's designed to enable us to rapidly identify groups within the population based on shared needs, and it provides the capability to drill down to individual level and cut across that full spectrum of risk of harm as a result of the COVID pandemic. That's in recognition of that very wide impact that we know the pandemic has had on the population. We know that it will affect people in many different ways, including mental health, socioeconomically, but ultimately all of that risk of harm is going to hit us as an integrated care system in one form or another. And this segmentation allows us a shared view between primary care and other providers within the system to start a conversation based on that common understanding around what the offer might look like for each of these groups, recognising their different needs. And the importance of this is enabling us to be able to target that action around the impact of the wider determinants of health with the view of reducing future demand within the system. So I've been working in partnership with Simon over recent months to develop an interventions matrix that could sit over the top of this segmentation tool as a way of thinking about what the current offer might look like for each of these groups and how we can enhance that to best meet their needs. So I'll now hand over to Simone just to talk about how she's used that data to create some benefits for her population.
Good afternoon, everybody. I hope you can hear me. So, yeah, I just want to thank Emily and everybody that's been working with the data analytics. It's just been a really incredible programme. And I suppose for us, where we're thinking about COVID, and I think it really brought to the fore the social prescribing effectiveness and the benefits from that approach to patients really and communities. And I suppose historically we were very lucky. The CCG had recognised social prescribing before network development and have funded some link workers and also some health coaches, which sat within the practices and the networks. And then, of course, with network development, we have funding through the additional role programme for more social prescribers. And I think that started us to think about how can we really use the data that we've got here to direct the workforce as one team, as opposed to it being a rather, well, prior to that, it'd been a little bit piecemeal, really, with everybody working within their own organisations, which is understandable, really. We'd also worked with the Altogether Better programme, and we've recognised the benefit of having patients as friends and health champions, and we've been overwhelmed really with the support and the volunteering from health champions to come and work within the practice, volunteer, run groups, and really offer a huge amount of support. And this has been embraced especially through COVID. If we go on to the next slide, please. So we were working using the data. We've been working with the data analytics team and just looking at specific cohorts, particularly at risk through COVID-19. We were looking at those with low to medium risk, for example, of COVID, so one long-term condition such as asthma or COPD, but also they had some coding there that made them stand out as being socially vulnerable, and how we could get our teams to reach out to these groups of patients and offer them support, either through practice nurses looking at their long-term condition management, which may have been neglected because of COVID-19, but also what social prescribing could do for these patients who are socially vulnerable and how we could really reach out to them. Because the other thing about this is it's not only about those people that come into the practice that don't have a medical need, it's also about those people that don't seek help at all, and they're out there in the communities and we really don't know about them. And this is again where, using the population health management approach, we can really start to target interventions and make a real difference. So we looked at cohorts, we worked with help and care, as you can see here, and we did a big mapping of all of our resources, really. So we were looking at how we could reach out and contact people proactively, how we still worked reactively within the surgeries and through signposting, through reception, and what really the resources were there. We have a huge amount, really, if we look at it: the health champions, the link workers, the health coaches, the expert patients, and of course we mustn't forget the clinicians. And then what actually is social prescribing? And I think sometimes it's a bit like population health management. People don't really understand it, and it really is just that starting conversation. What matters to you most? How are you? You know, what would make your life better? And I think for me, moving forward, we look at the network DES requirements that are coming out and talking about personalisation and anticipatory care. But the thing about this is it's not all about health. And this is why I'm really glad to be here at the Health and Wellbeing Board, because we need to ensure that the conversation is about well-being, and well-being and happiness are not just about health. It's about a person's housing, it's about their personal circumstances. And so this is where we really need to come together as a system and you know, work as one system, really. We've got lots of service offers, as you can see, and again, often it's just about tying those things together, and then about how we evaluate. This is a lovely busy slide, and I apologise, but this is really just to kind of demonstrate, actually, if we've got data, we know the groups of patients from that data, that gives us the groups. And then it's how do we define and target those interventions so that we're having a uniformed approach to different cohorts of the population. This writing is really tiny, but I can tell you that, you know, if you've got somebody who's at high risk of COVID, so they've got multiple long-term conditions, and also they've got social vulnerability and mental health resources, and they may need quite a significant intervention offer. It wouldn't just be a signposting from a social prescriber. It will be health coaching, it will be nurse practitioner involvement. It will also possibly be onboarding through the My Health app that we're looking at, so that they can manage their long-term condition more effectively remotely, because again, we need to reduce footfall into primary, secondary care. We need to make sure that we're keeping people as safe as possible remotely. And then, of course, we're looking now at potentially the sort of second stream of COVID, and it's actually those people we know are going to be more at serious risk of illness. How do we reach out to them proactively? That's really important. So, you know, and actually make sure they're aware that if they do get symptoms, how do they present? Because I think what we've learned from the first wave is that people presented late. We weren't aware so much of silent hypoxia. And so we've got the programme with pulse oximetry that we're just introducing, so that if we have people that are high at risk or have COVID symptoms, we can monitor their pulse oximetry remotely, you know, so that we can see that if they're developing, you know, their stats are dropping, we can get them into hospital sooner and reduce death rates. So, you know, there's so much that we can do working together, using population health management and using our whole clinical and non-clinical workforce across the system. Next slide, please. I think probably that's it in a nutshell, but again, just showing there's been so many stories, and I think I can tell you that out of 97 calls that our team made, 75% of those actually had some form of signposting intervention. And again, I think probably most people have heard these stories, but a lady who was isolated through lockdown, one of the link workers contacted her through the population health cohort data that we'd defined. She was very isolated. Her family had been due to travel over from Canada. They were unable to because of lockdown. The link worker found her funding for an iPad, so she was able to FaceTime her family really regularly. And so her patient activation measure, you know, increased from a 1 to a 3. You know, and once you start to see an improvement in happiness and well-being, you see an improvement in health outcomes as well. So, you know, this is a really important message for all of our system. So I think that's all the slides I was allowed today. I could go on forever, but I'll hand back. I think that's it, isn't it, Emily? I'll hand back to Emily, and then I don't know whether there are questions. Thank you so much.
Hi, thank you both, and that was very insightful. I suppose the the questions that came to my mind was that this, okay, being used hugely in our current times, but this is something which is very much ongoing, and you could analyze your community for whatever reason you're looking at, whether they're COVID susceptible or any other issue that you can plug into the system. Would that be right?
Yeah, that's right. And this data is being, it's live data, as I mentioned earlier, and we're continually developing that as well based on the changing landscape and users' needs. So it's very much developed in a sort of ground up approach, which is quite different to potentially what we've been used to in the past. And I think what makes it different is obviously it's linked data. So for the first time, we've not had to refer to different databases to access information. So it enables us to really start to get that joined up view of population needs, so that we're all looking through the same lens, so to speak, in terms of population need. And it's very much evolving day by day. It's not intended to be a static view. So yeah, welcome anybody's input once they send the link out after today, and people have an opportunity to go in and have a play around and start thinking about that. Then I'd very much welcome any further feedback or other conversations with individuals about that.
Thank you. That I was just wondering who has access. I imagine you wouldn't want it. It's going to be quite limited, but it looked to me like a powerful tool for some of our directors in children and adult social care, and all sorts of in place to analyse place. So this link will go to members of the board.
Yeah, that's right. The access to the device at the moment is open source because all of our patient data is pseudonymized. So people have to actively request re-identification at individual levels. So that enables a much broader range of individuals to be able to access that at the current time. So now's the time really to sort of get that in front of as many people as we can, so that people can start thinking about the opportunities that might present.
Brilliant. I've got two hands. One of them was Tim, and then the other one was Tony Meadows. So Tim.
Yeah, hi. I mean, really enjoyed the presentation. It's not a question. It's just an observation. Really, it's been really good to see this sort of evolve over sort of the last sort of 12+ months. Really, as one of the national pilots, and the way all the teams have come together to get all the information in one place to allow us to extract that sort of analysis puts us in a really good place. I know we've kind of been talking about it for a number of years. To actually see it live and real time has been just so pleasing to see, and especially valuable through the actual COVID period to have got effectively live links across all the various systems, so you could see every day. I was going in, especially at the start of this, and just to see the numbers of people in sort of the hospitals, in primary care, the care homes, the PPE stock levels, and you can only do that if all parts of the system are linked up to see that. And to see that then, fully evolve now into some of the more performance metrics, and effectively allow the whole population health management to come off the back of that type of integration as well. It's just been really good, and I just think we're in a really good place there to take things forward. And you can sort of hear the enthusiasm and passion in Simon's voice and other GPs that have been close to it, because the fact they can get back to the individual patients and then actually do something about it is so much better than a lot of the other things I've seen, which are similar to this, where they just give you, well, this is your population, but you don't know who they are. And if you don't know who they are, it's very interesting, but it's very difficult to do anything about it. So the fact that we've got it at patient level, so the GPs can actually then make contact and put people in the right point, in the right direction, is just been great to see. So I just want to sort of say sort of well done to the team for doing that.
Brilliant. Thanks, Tim. I've got Tony Meadows, John Selgren, and Simone. Did you want to say anything on the back of what Tim's just said, or do you want to come in after the other questions?
Yeah, I think, thank you. It was just to say, I think, thank you, Tim. I think it's really important this is embraced as a system, because, we have linked data, And as a system, we're fortunate that that work has been done. There hasn't been huge funding for it, and moving forward, you know, it does need to be a system approach, because this is the one way that we can tackle many of our sort of inequalities across the system. And again, just reiterating that it's not just about health as well. It's got to be about the other, you know, the rest of the system, so that contributes to people's happiness. So, but yeah, thank you so much.
Thank you, and agree with that, Tony. Meadow.
Thanks, Rebecca. Again, sort of echoing Tim, but just going a little bit further, I suppose. I mean, from a social care perspective, the opportunities that this gives us now. I mean, I've been following this piece of work for quite some time, and actually seeing it again, it's giving us an opportunity to now, when we're looking at strategy, to actually shape things in a completely different way, because the conversation becomes different when we actually understand our locality areas in a completely different dynamic. And I think one of the suggestions as well, maybe for the board, is how we want to look potentially at the Home First agenda, actually through this lens, because I think it gives us maybe an opportunity to begin to understand, if we're looking at actually supporting people to maintain their independence, what are some of the health challenges and the wellbeing challenges in certain communities, and getting a little bit more granular in terms of how we can be supporting that as a system.
Thank you, Tony. Great suggestion, and we'll certainly make a note of that and see how that might be followed up. John.
Thank you, Chair. Yeah, I was really taken with this presentation again, the comment made in the chat bar about that spatial information, and you kindly made the point this would be of interest to colleagues in place. Indeed, it would. So certainly, really with this, and indeed mindful of the last item, an opportunity to share some of this with my teams, with some of my own members who work with us in the place work. I think really what we've got to do as a group is now perhaps to begin to raise that wider awareness of this. I think a number of colleagues have quite rightly made that point, that this is a system challenge and therefore need a system response. So for me, part of the first step on that journey is sharing information like this and getting other colleagues to really engage with the extent to which they can help tackle this as a system response.
Thanks, John. It'd be really good to see it communicated across our council directorates, wouldn't it? It really gets your imagination going, and thank you. Forbes.
Okay, thank you. Just a few comments really. You know, I'm one of the people that has seen this before, but each time I see it, I enjoy it sort of more and more really, and appreciate the value of it. So really just to support what Tim largely said, but I just see how good it is. First point is a plea for social prescribers. I know Simone did it and keeps doing it, and I would like to support that. Social prescribers have been hugely valuable, particularly through COVID. Certainly in my area, they've really addressed what I would consider to be a significant unmet need, particularly of isolation through COVID. And if we did not have those people working in the way that they've worked, a lot of that would have found its way to primary care and presented in other ways. So we are rolling that out more widely, and we are rolling it out across the system so other organisations can access that service. And I think we should really, one, applaud the work that's been done, and two, look to see how we can further develop the role. The second thing is the point that has been made, which is about just sharing the information and the intelligence we have across partner organisations within our ICS. So this is an example of that, and our earlier presentation was about the insight. So, and it's how we translate that into action. Well, through population health, I think that is how we can clearly do it. So we need to make sure we're joining up that insight JSNA work with the DICE and the population health management work. You know, I was on a call this morning just reflecting on what was said this afternoon about, you know, shaping services that are best met to meet people's needs. And it was talking about Yorkshire and West Yorkshire, and they were saying that actually through COVID they discovered that only 27% of the British, Pakistani and Bangladeshi shielded population were even registered with a GP. And they said that's not because they're hard to reach, it's because the services that we have aren't accessible in a way that would work for them. And it's just, you know, a very stark point, isn't it? But it's something we should just bear in mind as we design, as Chris said earlier, our new models of care.
Thank you.
Thanks. Really good points. And I just a quick question: how are GPs across the localities using this information? I mean, obviously, Simone, you are up in the Blackmore Vale Partnership area, but is it well known yet, or is this also rolling out within the partnership?
So there's been wave pilots and waves. So I was lucky, I was in the wave 1 pilot, and we worked with NHS England with another couple of networks. Emily's been involved in the wave 2 rollout, and she'll correct me if I'm wrong. And then we've got the wave 3 to start on now. So, and it's used across networks in various ways. As I said, there's a piece of work now with COPD and the onboarding with the MyM Health app, which is a way of self-care for COPD, looking at patients, again, using the data to recognise patients at rising risk of illness with COPD, especially with COVID, and onboarding with pulse oximetry. So that's again one way that some networks are using it. There's a hypertension rollout looking at, and then high intensity users as well. So looking at those patients with heavy footfall into services and actually identifying them, because we think we know them all, but we don't. We'll know some of them, but we'll never know all of them. Obviously, for some of them, there are lots of reasons why they're high intensity users, and that's correct. But for those actually that may be being directed to the wrong place, we can then identify them and work out and work with them so that we wrap around them, as opposed to they involve multiple agencies. I'm sure Emily will come in now, but yeah, it is being used in lots of ways. Again, like everything, it needs time and a little bit of resource, but it sits through everything we do, and the network requirements that are coming out. It's more and more population health based. So yes, we're ahead of the game in some respects. But Emily, would you like to come in?
Yeah, I mean, I think you've covered it quite nicely there, Simone. And as you say, I think networks are using it in a variety of different ways, from things like approaching planning of clinics differently in terms of prioritisation of particular patients that they want to bring in, and not bringing in those that are actually doing very well. Thank you very much already. So therefore, let's not waste time necessarily with clogging up clinics with those individuals and focusing more on those that need to be seen. But as you say, also in more innovative ways in terms of introduction of digital self-care at home and being able to identify cohorts that may be able to best benefit from those types of interventions. So I'd say quite a full range. And just to pick up on a couple of comments earlier around, I think now definitely there is quite a good awareness across the system. I think I've probably presented these COVID insights to now probably about 800 people in the last 2 months across providers, teams and directorates, including VCSOs, the local councils, just recently the allied health professionals. So a really good mix of individuals. So I think now is the time to strike whilst the iron's hot in terms of that awareness being quite high for those sorts of onward conversations around how do we now move that one step further in terms of that partnership working.
Thank you both. That was really interesting, and already I'm sure people are thinking about how they can use it. So anybody else on the board to comment, but just to say thank you, and really, really helpful tool. Thank you. Right. We will now move on to item number 10, which is an appointment to the Dorset Local Nature Partnership Board. I'd like to thank Dr. David Haynes. He was our board member for a very long time and did a fantastic job there, and we're fully engaged with the partnership board in terms of the health and well-being agenda now. I haven't heard of any nominations, but is anyone on the board at the moment wishing to self-nominate or nominate somebody else? Perhaps we need to. Yeah, is that a no? it's a really good relationship that both John's department have from Dorset Council. We as a board do, and it's all about the natural prescription, and whether it's natural or actual social subscribing. John, would you like to say something on this one?
Rebecca, sorry, Chair, just to support exactly what you said. I mean, I do appreciate that many colleagues on this call have very strong focus around and expertise in health, but how valuable it is for services that we have a close interest in place as part of that preventative agenda. So, you know, our colleagues who work around this area of the business are very, very aware of how important a role they play in prevention. So the involvement of somebody from this board onto that work would be extremely helpful. So again, I'd perhaps offer two things. If any colleague on this call is being a little bit nervous, a little bit wilting violet, oh, I'm not sure I know about all that environmental stuff, it will be all whatever you might perceive environmental colleagues to be, I can assure it's not like that. It is a good opportunity, actually, if this is an area you may be less familiar with. Certainly I know that those involved in this will want to give you a good induction and make sure that you've got a good understanding of their work. So please don't consider that you need in-depth expertise in this area or necessarily a good existing understanding of it. It will be just as helpful to have somebody who'll bring that broader perspective to their work and for them to allow you to share a bit more of their world with you. So do please see it as much as a potential for development opportunities, it will be for someone who perhaps comes with a lot of existing expertise.
Thanks, John. And I know that there are representatives from Dorset Council on it. Now, I don't want it's all buzzing in the side here, but I'm not seeing if there's anybody. No, I really want to see a Health and Wellbeing Board member to continue that relationship. So
I think Chris.
Someone wants to. Who's that? Sorry.
I think Chris has put himself forward, which seems like that might be quite a good connection. Chris Skelly.
Hang on a minute. Right. Who's speaking? I can't see.
Laura, sorry, it's Laura
Oh,
Miller.
Laura, hello.
I just saw in the chat bar that Chris Skelly's put himself forward, and with the brilliant presentation he's just given, that seems like it might be quite a good. Just for your attention, if you didn't see it.
No, I didn't. I missed that one.
Sorry, Chair.
Hello, Chair.
Hello.
It's Rachel Partridge here. Just to say that
I come to you.
that I do attend, but I'm not there as part of as the rep for the Health and Wellbeing Board. So I didn't want to volunteer as Health and Wellbeing Board because I think there is real benefit of other people being involved, just as John's indicating. Yeah. But I just wanted to say that I do attend, but
yes,
not officially as Health and Wellbeing.
You've been instrumental in joining up. Chris Skelly, have you volunteered to? Well, actually, Chris, you're not a member of this board.
That's right.
So, but I'm sure you'd be very welcome. Absolutely. As I was saying, I really want to see the board represented because I think it helps the local nature partnership as well. So if anyone wants to nominate me, I will do it as a sort of keeping the seat warm, and hopefully we can actually we'll need a deputy, but maybe for now, if that arrangement would suit the board, I'd be very happy to.
I'll nominate Rebecca Knox.
Who's that?
Spencer.
Rebecca.
Spencer. Okay. Hang on. Oh. Yes, Laura.
Oh, okay. Sorry, my stupid internet was being stupid. Yeah, just a quick point. I'm very happy if you want to do a seat warming job. We do have some new lead members in care and health, and I wonder if this might be something that we could put to them later. But if we do already have Dorset Council representatives, it might be nice to have someone from health. I'm not quite sure, but I think maybe we could have like maybe a further discussion. I think wanted to.
Yeah, no, let's do because this is a specific health and wellbeing board member. But Laura, you're absolutely right. There's a really good opening, and I'm sure that conversation with John and the partnership would be great for those other lead members. Brilliant. Forbes.
Yeah, my point was really the connection with health. Very happy for you to undertake the think seat warming, as Laura has said, on behalf of the board. I couldn't commit it to it myself, but I know David found it very valuable. And I'm just, perhaps I can pick up a conversation with, I think John might be the best person, and or Rachel outside of this, to discuss making sure that we have got the health voice. You know, we've just spent an hour and a half talking about health and well-being, in essence, haven't we, really? And working at place. And I think we should have some health input to make sure we're getting the messages out from the local nature partnership, particularly through our evolving primary care networks. So I'm happy to take that outside the meeting, but I just can't commit to being one of the present health and wellbeing board members. That's all I would say.
Thanks, Forbes. We might find that we can do it in another way, but let's ensure that the partnership knows the board is really keen to keep that relationship. John?
Chair, and if anybody did want an informal chat about it, I'm more than happy to act as that point of contact and can perhaps just talk through what it involves and perhaps make some early introductions.
Yeah, that's fantastic. So that looks like Forbes, Laura, John, and I just sort of gather thoughts and have a think about how this will work properly for the board and others, and involve Chris, who looked like was keen to join in or understand more. Were there any more hands? There were some, and I can't see anything else in the chat box saying no. I think the last one was Laura. That was you. Thank you very much for that intervention. So we'll do that as I said, as just to ensure there's a permanent link with the board. And the next item on the agenda was any urgent items. Helen, are there any urgent items?
There are no urgent items, thank you, Chairman.
Okay. And I don't believe there is any exempt business.
No, that's correct, Chairman.
Thank you. Before we disappear, just to we don't have a forward plan at the moment because, of course, we're in a position where we want to bring items that are very relevant to our current situation. But there is one which I'm going to suggest goes forward. I'll put it into the minutes now and hope that it gets there, and that's a continuation of our work that has been ongoing and was stalled a bit for the COVID, but if there is space on the next agenda, I'd like to bring back health in all policies. And the other item that we were going to hear today was about the discharge to assess. So those two, if we can, that would be great. Has anyone got anything else as a suggestion? And of course, the follow-up to the insight work. But any thoughts between meetings, please get in touch with Helen or me or Forbes. Thank you. And thank you very much, everybody. We've just come in before 4 o'clock. I know we put 3 hours in your diaries. It never is. But thank you. And see you all next time. We'll chat between then and now. Then and now. Thank you all.